Hello and welcome to this video from the Evidence-Based Medicine series on critical appraisal. I am Professor Anthony Cummins from the Department of Family Medicine at RCSI Perdana. The first thing you see here is a link called Evidence Bully, and it's actually a link to James McCormick's video, which is entertaining and hugely informative on the importance and value of an evidence-based approach to patient care. You can look at this in your own time. So what is critical appraisal? Well, it's the systematic and thorough evaluation of clinical research papers in order to establish 5 things. Does a study address a clearly focused question? It's amazing how often studies, and often lengthy studies, are produced but have not addressed a clearly focused question. The question is the most central and important component of research. So, if you clear the first hurdle, you do have a clearly focused question. Did the study then use valid methods to address this question? Next, are these valid results of the study important? And by important, I mean important to the general public, important to the world at large, not just to researchers and investigators. So, are these valid, important results applicable to a patient of mine or to a population of patients? And in summary, if the answer to any of these foregoing questions is no, then save yourself a lot of hassle and stop reading this paper. Go on to something more interesting. When you hear of a publication or see a publication, you hear about a media statement about some new wonder drug, always ask 3 questions. Are the results valid? What are the results? And will these results help me care for my patient? So in terms of the validity of the results, you should be looking for sources of bias. If this was a therapy trial, was randomization done? Is it explicitly stated in the paper? And was the method of randomization clarified without any doubt? Was there blinding? In other words, were the participants and the clinical investigators, the study researchers, each blinded to each other's status? So neither the investigators knew which therapy the patients were taking, and neither did the patients. This is double blinding. Was there allocation concealment? If there was not, then this could induce bias in the results. And was the study conducted on an intention to treat basis? This is also something that's essential to reduce bias. Was there follow-up, and was follow-up complete? If there was loss to follow-up, how big are the numbers lost to follow-up? This could seriously skew the results. Of those lost to follow-up, are there clear explanations of why they were lost to follow-up? Are there conflicts of interest? These are often pecuniary. A lot of randomized controlled trials nowadays are conducted by or with funding from the pharmaceutical industry. Members of various regulatory bodies such as the FDA may have a conflict of interest in that they may be paid in part by sections of the pharmaceutical industry. Conflicts of interest must be stated explicitly in the paper. So what are the results? The paper should clearly show and demonstrate to you without any doubt the size of the effect. They should quote both relative and absolute numbers. Relative numbers are always larger, percentages in excess of 10% and sometimes well above that, which can be very convincing. But the absolute numbers are also very important to know. They should show confidence intervals around the effect seen. And we should get some idea from this of the precision of the results. The next question you want to ask is, will these results help me to care for my patient? So is my patient similar to the population recruited for this study? Are the populations in the trials as part of a systematic review? Are the outcomes important? Important to me, important to my patient? And have all important outcomes been considered? And all relevant outcomes been considered? What about patient preferences and patient values? Have these been taken into account? We'll now go on in class to appraise a series of papers, and we will use the tools from the Centre for Evidence-Based Medicine at Oxford, whose website here provides a very, very clear introduction to the whole approach of evidence-based medicine. Plus, it provides critical appraisal worksheets for systematic review, for prognosis, and for therapy that's for a randomized control trial, a single randomized control trial. So we'll look at these appraisal worksheets now, and then at the end of this presentation we will then conduct a series of appraisals of clinical papers. First of all, look at how the paper is appraised. There's a method they use at Oxford called RAMBO. This is the mnemonic for it, and it stands for Representative, Allocation, Maintenance, Measurements, Blindedness, Objective. So let's look at these in turn. Are these patients representative? Representative of whom? Well, of the general population, for example. Or are they specific patients? So are they a particular nationality, a particular occupational group, etc.? If they are, then they may not be A, representative of the population at large, and B, may not be relevant to the patient you have sitting in front of you. Was allocation concealment practiced, and is it clear from the paper? And was assignment of treatments randomized, and did they clarify the method of randomization? Also, you should see in the paper a table showing the structure of the groups in, for example, a therapy trial, a randomized control trial, and they should be similar in terms of relative gender distribution, age, previous medical history, previous therapy, current therapy, etc. So that effectively the only difference between these two groups is largely the treatment under scrutiny. And as the trial evolved, were the patients in both groups treated equally? Were outcomes ascertained and analysed for most patients? It may not be possible to get them for all patients, but for those who are lost to follow-up, are these accounted for? Were measurements that were conducted, were measurements blinded and objective? And if the answer to any of these is unclear or no, then you would lose faith in the paper that you are reviewing. Okay, this is not what you think it is. This stands for 3 characteristics or attributes of clinical research. It should be wise, it should be true, and it should be fair. It should be a fair comparison between one treatment and another. The results should be true and therefore valid and reliable and credible, and it should be wise and relevant and important to the world at large, the public at large. So let's look now at some of these sheets. The first one is a prognosis sheet, and these are useful to have with you when you do your critical appraisal. So the first thing you want to know about, are the results valid? This is about internal validity within the study population. So was the defined representative sample of patients assembled at a common, usually early point in the course of their disease? So this is looking at an inception cohort. In other words, a group of patients in whom you're going to follow them up for a period of time to see that they develop a particular illness, for example. You may also have a retrospective cohort where you start off with people who have an illness currently, and then you look back at their records, their past history, to see where they exposed to a particular toxin, etc. in the previous 10, 20, 30 years. So in the method section, it should be very clear at which stage this patients entered the study, and they should also provide information about how they were recruited from primary care, tertiary referral settings. This will have a bearing on their relative level of disease and so on. So if you're clear about this, you tick yes. If not, no. If you're not sure, just tick on clear, and then you may want to write a comment, and then you carry on to the next section of the appraisal sheet. The next section was patient follow-up sufficiently long and complete. So in a cohort study looking at a question on prognosis, clearly the length of time that the study lasts is important. And in fact, for some outcomes that are uncommon or rare, then you may have to continue this cohort study for several years. But all patients should be followed up from the beginning of the study until the outcome or death occurs. And any reasons for non-follow-up should be provided, along with a comparison of the patients who were lost to follow-up with those who were continued in the study. And all of this should be available in the results section. And it should also clarify the number and reasons for loss to follow-up. It's important to have this information and also to see the breakdown of these patients, to compare them to those who remained in the study. Again, if it's yes or no or unclear, you may wish to make a comment. So were outcome criteria objective or applied in a blinded fashion? There should be a clear definition at the outset of all the outcomes, and that should be in the method section. And this may also be included in the results section. Again, click yes, no, or unclear if you're not sure. Now, if there is a large population or cohort study, if there were subgroups of different prognosis identified, was there adjustment for important prognostic factors? So prognostic factors may be age or stage of disease. So for example, class 4 New York Heart Association heart failure has a worse prognosis than class 1. And this will predict the outcome. So a study looking at this should adjust for these various prognostic factors. Also, comorbidities, patients with, for example, NYHA class 4 heart failure, plus depression, plus anemia, and other comorbidities will have a worse prognosis. So the results section should identify any of these prognostic factors and whether or not they've been adjusted. And you might find in the tables that there's a separate survival curves for patients at different stages of a disease or for different age groups or different comorbidity burden. Again, if it's clear, yes, and then move on. You look at the results and you look at how likely these outcomes are over time. Now you can see here, this is a survival curve. Everybody alive at the onset, and then this is a passage of time over years. And by 5 years, these 3 different groups have reached a survival rate of 20%. But they've arrived there through different routes. So the group in green, their survival rate plummeted very rapidly within 1 year, but then it plateaued off. Whereas the blue group had maintained their survival rate for quite a while. So by the end of 1 year, there were many more of these alive than the group in green, but gradually this reduced until by year 5, the 5-year survival rate was the same as 20%. And the group in red were intermediate. So just knowing the total 5-year survival rate only doesn't give you the full picture. We need to find out the path to this ultimate 5-year survival rate. Because this summary figure would obscure important differences in these different patient groups. To look at the precision of the prognostic estimates, we need to look at the confidence intervals. By convention, this is 95% confidence interval. The narrower the confidence interval, the more useful the estimate. The precision depends on the number of observations. So the more observations, the longer the study, the more precise these figures are. And you find in the tail end of a cohort study, for example, estimates of the survival at the end of the follow-up period are relatively imprecise and can be affected by what happens to just a small number of people who are still remaining in the study. But the next thing you want to ask is, can I apply this evidence about prognosis to my patient? You need to ask, is my patient so different to those in the study that these results can't apply? And also, will this evidence make a clinically important impact on my conclusions about what management or strategy to offer my patients? Now let's look at the systematic review appraisal sheet. The first thing you look at here again is the quality of the question, how well structured the question was, and did they actually specify a question. Now some papers will actually elaborate on this and structure their question as a PICO in the abstract and in the introduction to the paper. The title and abstract and the final paragraph and the introduction should clearly answer this question for you. If they have not ascertained a focused question, then you should probably give up on this paper and move on. Life is short. Is it unlikely that important relevant studies were missed? Now, this is a systematic review looking at a thorough review of several studies. There may be therapy studies like randomized controlled trials. There could also be diagnostic accuracy or a whole lot of other types of different studies. The most common one would be a randomized controlled trial for therapy. So, if the researchers in the methods section list a comprehensive list of databases such as Medline, Cochrane, Embase, etc., and also include a search of reference lists from the studies that they received from these, and also making email contact and other contact with experts, and also to look at grey literature, conference presentations, and not limiting their search to English language only, and also in their search strategy, in, let's say, PubMed, using keywords and mesh terms, well, you know this is a comprehensive study. So the likelihood that important relevant studies were missed is very unlikely. And were the criteria used to select articles for inclusion and exclusion appropriate? So you should see that also in the methods section. They should have explicit inclusion and exclusion criteria. And if they don't include these, if it's not clear from the study, then move on, leave the paper and find something else. You then need to look at the different studies included for the review and were these individually valid for the question being asked. Again, you should find this in the methods section. They should look at the quality of each component study and how that was assessed. That there will be standard criteria for assessing study quality, and these often come from the Cochrane. There are Cochrane criteria for this. The results section also should make reference to the quality of the information in the individual study component parts of the review. We now need to look at the comparison from study to study. So if there is a huge variation between one study and another, or between all of the studies, then this means these are heterogeneous and not homogeneous. They're not alike, they're different. And if they're different, how different are they? And there's an agreed convention about the level of difference between studies, and this is expressed as the heterogeneity, and it's often put down as I2 or I squared or X or degrees of freedom. So in the results section and also on the various forest plots for the systematic review, you should see reference to the level of heterogeneity. Because if it is significant, certainly if it's above 50%, it would make you want to seriously question the conclusions of the review. So then you look at the results, and the results are best presented. They're presented both textually but also visually as a forest plot. And this example here is looking at a systematic review of 5 studies. This line here is called the line of no effect. And any individual study that lies wholly on this side of the line will favor the treatment in this case. Any study wholly on this side of the line of no effect will favor control. And you can see these are the individual studies. Each one has a confidence interval, and each one has an effect. And this is an indication of the precision of the effect. So the bigger this dark square, the more precise are the results. The smaller or the narrower this line, this horizontal line, the confidence interval, again, the more valid the results, the more reliable, and the more likely you are to make valid conclusions from it. This one, for example, has a very wide confidence interval, which crosses the line of no effect, as does this one and this one. These two do not. And it looks from this as the overall result. This is the pooled estimate. The overall result favors treatment. The precision of this study must be so high that it dwarfs all of these and leads to this pooled estimate, which is quite definitely in favor of treatment. And you can see here by the weight attached to this particular study is 51%, much higher than all the others. So this is a very useful way to represent results from a systematic review of randomized controlled trials and their meta-analysis. And you can see, as mentioned here, tests for heterogeneity using chi-squared and degrees of freedom, as well as z-score. This is just exploring what I've just discussed about the forest plot and heterogeneity. Now let's look at a randomized control trial, a single randomized control trial. The first question again, as in the other sheets, are the results of the trial valid? So first of all, they should make it quite clear what the PICO question is. They should explain the patients, the intervention, the comparison, and the outcome. We then want to ask, was the assignment of patients randomized? You should find this in the methods section, and they should clarify how the randomization was actually conducted. Was it centralized computer randomization? But there may be a lesser method than that, but you need to check both the randomization and the allocation concealment. So were the groups similar at the outset of the study? You should find this in the results section, which should have a baseline characteristics of both groups. And the only difference between them should be the treatment under scrutiny. Were the groups treated equally otherwise? In other words, we are making the allocated treatment the only focus of difference and the focus of scrutiny. There were no other significant differences in their original baseline characteristics and subsequently how they were managed. This should all be clear in the methods section. You may find some of it in the results section also. Was everybody accounted for? Was there loss to follow-up? If so, this should be clear in the results section. And if patients were lost to follow-up, A, they should be explained and clarified and reasons given, and B, their baseline characteristics should tell us whether they were more ill than the patients who stayed in the study and therefore could bias the results. When the measures used in the study were the objective and were patients and clinicians blinded to which treatment was being received. This is an ideal situation, and we should look in the methods section to find out if this randomized controlled trial is truly double-blinded. Both patients and researchers were unaware of treatment allocation. It's less crucial for things that are objective, like death or pregnancy. But if it's subjective, and if it's a continuous outcome like blood pressure, cholesterol level, or clinical symptoms, then blinding is absolutely essential. The methods section should make this quite clear. And first of all, you need to look at the results and see the effect of the treatment. What is the size of the treatment effect? So you're looking at ways of expressing the treatment effect results. So for example, in a study in which 15% of the control group died and 10% of the treatment group after 2 years of treatment, how could these results be expressed? Well, they could be expressed as a relative risk reduction. That means the risk of the outcome in the treatment group divided by the risk of the outcome in the control group, written often as RR, and that would be 0.1 over 0.15, 0.67 is the relative risk reduction. What this tells us is how many more times more likely it is that an event will occur in the treatment group relative to the control group. So if the RR was 1, then the likelihood of this event occurring is the same in both groups. If it's less than 1, it means that the treatment decreases the outcome. If it's more than 1, it means increase the risk of the outcome. So in this case, we're looking at mortality, and since this was 0.67, that's less than 1, so therefore this treatment reduced the risk of death in this case. It can also be expressed as an absolute risk reduction, which is the risk of the outcome in the control group minus the risk of the outcome in the treatment group. This is sometimes also referred to as the absolute risk difference, or ARD. So this tells us the raw numbers. So if the ARR is 0, there's no difference, which means that the treatment has had no effect. So in this example, it was 15% and 10%, so the difference is 5%. So there's a 5% reduction in the death rate in this study. There's also a relative risk reduction, which is the absolute risk reduction divided by the risk of the outcome in the control group. So you can calculate the relative risk reduction with this formula as 1 minus the risk ratio. So another example, it would be 1 minus the risk ratio, which is 0.67, and that would turn out to be 33%. So that means that the treatment that reduced the mortality absolutely by 5% can also be expressed as having reduced it by 33% relative to that occurring in the control group. Another useful parameter is number needed to treat, and this is the inverse of the absolute risk reduction. It's calculated as 1 divided by the absolute risk reduction. So in this case, it was 1 divided by 0.05, and that gives you a figure of 20. So that means that a practicing doctor will need to treat 20 people for 2 years in order to prevent one event, death in this case. Similarly, when it's looking at harms as opposed to benefits, you may also calculate the number needed to harm in the similar fashion. So how precise was the estimate of the treatment effect? We may not know the true risk of the population, and therefore the best we can do is estimate it as accurately as possible. This is called the point estimate. We can gauge how close this is to the true value by looking at the confidence intervals for each estimate. If it's narrow, then we can be confident that our point estimate is fairly precise. And it also gives you some idea about the statistical significance of the result. And if the confidence interval includes the value corresponding to the null effect or no effect, then the results would be statistically insignificant. So will these results help you to care for your patient? This is about external validity as opposed to internal validity and applicability. So again, is my patient so different? Is the treatment feasible? And will the benefits outweigh potential harms? These are some resources for you. We've covered these in another video. This is PubMed for Handheld. This is the Oxford Centre for Evidence-Based Medicine. This is evidence updates from BMG and McMaster. This is Cochrane Pearls. These are practical evidence about real-life situations in primary care. And this is from Students for Best Evidence. So let us go ahead and critically appraise. Thank you.